Hello everyone. Today we are going to discuss the blockers, the autonomic blockers. We will dedicate this video and the following one to explaining the alpha blockers. But before we begin with the alpha blockers, I want to remind you of something important in physiology. Two types of reflexes related to our topic, and we will encounter them very often. So I want you to understand their basis whenever you hear about them. We have two types of something called Baro-reflex or Baro-reflexes. The first type of Baro-reflex states that when a human lies in a supine position, while in supine position, the body doesn't exert much effort regarding the distribution of blood. Why? Because blood is already distributed by gravity. Therefore, the body doesn't exert effort inducing vasoconstriction nor vasodilation. Either way, blood is equally distributed. However, when you stay sleeping for a long period, then you change your position from supine to standing position abruptly. Or if you stand from the bed suddenly, blood becomes subjected to a state of pooling from the upper half of the body into the lower half. This pooling process could markedly decrease your body pressure. For the body to prevent this decrease in pressure brought up by this change, it induces reflex vasoconstriction. Where? In the lower extremity, more in the lower extremity. So when it induces vasoconstriction and noradrenal release, the blood doesn't fall or pool in the lower extremity, saving the pressure from the marked drop. Okay, now some people come to the clinics complaining like this. Doctor, while I'm lying, everything is okay, but once I get up from bed, once I stand up, I feel like everything is moving. I feel dizzy and I fall down to the ground. Here, this man is said to have a condition called postural, or sometimes they call it orthostatic hypotension. Both postural and orthostatic are the same. This man who has this complaint has something wrong in the Baro-reflex that I mentioned. When he's lying down in supine position for a long period, then suddenly changes his position, the body is incapable of inducing vasoconstriction in the lower extremities, in the veins and the arteries down here. Accordingly, blood undergoes a state of pooling, the pressure is decreased. The drop in the stool is around 20 mm Hg, because the diagnosis of this condition is made by ensuring there is a drop of the pressure more than 20 in the stool within 3 minutes, okay? What is the reason behind this condition? So many reasons. Maybe a disease like diabetes mellitus can cause such condition. Maybe someone with a problem in his autonomic nerves, which means autonomic neuropathy. His nerves are damaged. The autonomic system is not functioning properly. Maybe drugs can cause this condition, such as a family called tricyclic antidepressants. Tricyclic antidepressants are a class of drugs that we will study together in the CNS. Antidepressants sometimes induce this condition, as do alpha blockers that will be discussed today. The reason I'm explaining this part is that alpha blockers that will be discussed today induce this condition. Thus, one of the drawbacks of alpha blockers is blocking the alpha receptor, preventing the occurrence of this reflex. Therefore, a man who took an alpha blocker and went to sleep, say he took an alpha blocker at night, then he slept. Later, when he woke up, he felt his head spinning. What happened to him is something called postural or orthostatic hypotension. This condition could be treated. Naturally, it's considered a medical problem and very difficult to treat. However, you can help this patient by giving him something that induces vasoconstriction. Search for a drug from the ones we discussed before that causes vasoconstriction. They were three besides one another in one line. Do you remember their names? Phenylephrine, something called methoxamine, and something called midodrine. Look for one of these three that may help the patient, hoping to help induce vasoconstriction in the lower extremity, thus preventing this pooling. This is the first topic that I need you to understand. The second topic is one that we studied together. Let me refresh your memory and add a little more detail. Do you remember when I told you if the pressure is suddenly increased, suddenly exceeding 170 in systole? Here is the heart, here is an aortic arch. Do you remember when I told you that here in the aortic arch are receptors, or better called stretch receptors? When the pressure is elevated suddenly, stretch receptors send signals to the cardioinhibitory center in the medulla, and this reflex is vagally mediated with the purpose of causing bradycardia. Do you remember this story? You must remember it well, as it will be repeated very often. And I told you then that this reflex is not related to any specific drug. Any drug whatsoever that suddenly changes or elevates blood pressure, leading to a stool above 170 can trigger this reflex. Today I'll add the opposite scenario. Let's switch the situation. If a drug is given or anything happens that leads to a sudden lowering of blood pressure, causing it to drop suddenly, do you think if the pressure is lowered, these stretch receptors will also cause bradycardia? Or does the opposite occur? The opposite occurs. These stretch receptors also send signals to the brain, but this time not through the vagus, as the vagus would cause brady. Instead, they send signals to the sympathetic system. Therefore, the sympathetic system responds by triggering reflex tachycardia. So, remember from now on that a sudden change, a sudden rise in blood pressure, sudden rise, causes reflex bradycardia. A sudden drop causes reflex tachycardia. Look, what I have mentioned is the rule. However, what is the exception of this rule? The exception might be that the drug causing this sudden change in the blood pressure is also the reason. The same drug that caused sudden rise may have a direct effect on itself on the heart. It may stimulate or inhibit the beta receptors. If it happens that the drug affects the blood pressure either by elevating or lowering it, and it has itself a direct effect on the heart, then these reflexes don't occur, not bradycardia nor tachycardia. I'll give you an example with adrenaline. Do you remember adrenaline that was mentioned earlier? Do you remember when we mentioned that adrenaline causes hypertension? When we use adrenaline, do you remember it increasing the systolic blood pressure? However, if you are smart and well attentive, you would know that adrenaline can never cause bradycardia. We never mentioned that using epinephrine causes reflex bradycardia, but it increased the pressure. What is the reason behind this? If someone asks, you tell him, look doctor, indeed epinephrine elevated the pressure, and stretch receptors sensed that, yes, and they reached out to the higher centers crying for help. But when this reflex tries to help, it finds epinephrine standing here in the heart on the beta receptors stimulating them. Therefore, it can't cause bradycardia as the epinephrine itself is a direct stimulant for the beta receptors. Despite similar examples, consider contrasting cases. If you are using a beta blocker, a drug that lowers the pressure, it blocks the beta receptor. Do beta blockers, when they lower the pressure, trigger reflex tachy? No, they never trigger reflex tachy. Why? Because when the pressure is decreased, stretch receptors send to the brain warning it against the lowered pressure and telling it to trigger reflex tachy. When it triggers reflex tachy, it finds the beta receptors are already blocking the beta receptors, so it can't cause tachycardia. To sum up, both reflex brady and reflex tachy appear with any change in blood pressure, unless the drug responsible for it has a direct effect on the beta receptors on the heart. We're done with this point, and please don't forget it because it's very important and you may be deceived in an MCQ and make a mistake. Let's move on to our main topic of today, to which this video is dedicated, which is the alpha blockers. Let's classify the alpha blockers and illustrate them. I hope this video will suffice, or we may divide it into two videos. What are the alpha blockers that we have? Or to be more exact, you can say alpha adrenoreceptor blockers. It's more accurate to say alpha adrenergic or adrenoreceptor blockers. What are they? We have four major alpha blocker classes or families. Not drugs, not four drugs, no, but four families. The first family is the group of drugs that block alpha 1 and alpha 2 together. Thus, it's called non-selective alpha blockers. Let's take an example by a drug called phenoxybenzamine. Phenoxybenzamine. And its brother, phentolamine. Both begin with PH. Phentolamine, okay? There are drugs that block alpha 1 only, thus they are called selective. Selective alpha 1 blockers. Like what? Such as a drug called Prazosin and its sisters. What are its sisters? Prazosin, doxazosin, tirazosin, enduramin, tamsulosin. These are some names. However, Prazosin, it is a prototype. Do you remember the meaning of prototype? Remember it. Okay, 3. We have drugs that block alpha 2 only. So they are called selective alpha 2 blockers. It is just a single orphan drug. Orphan. It has nobody else through the whole curriculum. It's called Yohimbine. And I'll tell you at the end of this video, when we reach it, I'll tell you why didn't they make another drug? Why did they suffice with one drug and why is it orphan? The last family, number 4, here 1, 2, 3, 4. The last family that's related to alpha blockers, even though some may object to placing it in this classification, this family is called ergot alkaloids. We will dedicate a separate video to this family only, and it's better not to be classified with the alpha blockers but should have its own classification, and you will know why when we reach it. Again, if you have an oral exam and someone asks you if you know about alpha blockers, you would say, I do. If he asks you to mention their names, tell him we have a family that blocks alpha 1 and 2 like a drug called phenoxybenzamine and phentolamine. A family that only blocks alpha 1 like this. Family that only blocks alpha 2 like Yohimbine. Then the ergot alkaloids. Now let's delve into details and discuss them one by one in depth. I'll start with the drug called phenoxybenzamine. Phenoxybenzamine. First of all, phenoxybenzamine is from a chemical family called beta-haloalkylamine. Don't bother with the chemistry. But what is this phenoxybenzamine? What is its character? They say this drug blocks alpha 1 and alpha 2 together. So it's a non-selective alpha blocker. And when it blocks them, it does it aggressively. Which means it makes a bond with the receptor called covalent bond. When you hear the term covalent bond, you should know that it means a very strong bond, impossible to be reversed, doesn't get broken. Hence, when the drug blocks alpha 1 and alpha 2, it becomes irreversible. When we say irreversible, it doesn't mean forever. It doesn't mean an irreversible drug would last for 10 years. No. Irreversible means it won't leave the receptor until the body metabolizes the drug, eliminates it, breaks down the receptor, and synthesizes a new receptor. Okay, this story lasts about 4 days. When you swallow a tablet of phenoxybenzamine, it remains blocking the alpha receptors 1 and 2 for the period of 4 days. Within these 4 days, your body destroys the receptor, it undergoes endocytosis, eliminates the drug, and synthesizes a new receptor. Because the receptor that was bound to the drug is far gone, beyond repair, wasted. Okay, a drug with such a character, naturally, we will use it in many cases. However, after it lowers the pressure, I'll give you a hint. When the pressure is lowered as it blocks the alpha, because when you block the alpha, you prevent the what? Blood vessels have alpha for vasoconstriction. When you block the alpha receptor, then the vasoconstriction is not going to occur in your body. So your blood pressure is lowered, and when your blood pressure is lowered, it's accompanied by what reflex? What? Reflex tachycardia. So it's one of its drawbacks. It markedly lowers the pressure and triggers your reflex tachycardia, which we mentioned earlier. So what are the uses of this drug? What is its major use? We used to enumerate many uses of it in the past. However, after we had a long discussion, we found out that most of the uses of phenoxybenzamine don't carry much significance for you when you become a general practitioner. After you graduate, you won't get in touch with these cases in which we need phenoxybenzamine. Thus, we agreed to make the life of the students better and suffice with one indication that's explained in detail to be well understood. The rest of the indications were deleted from the past 2 editions of your book. They are no longer required from you, so if you encounter an outdated MCQ question in an outdated source or in our book but 10 years ago, then don't bother with it. You are only required to study this one indication. Phenoxybenzamine is used for treating a case that you know, I mentioned it before, called phenochromocytoma. Phenochromocystoma, do you remember when I told you that some people have a certain type of tumor that arises from the suprarenal gland? This tumor is usually unilateral, arising from one side, and mostly is not malignant but benign. The problem of this tumor is that it releases too much adrenaline, which takes its toll on the alpha receptors and also on the beta receptors. So the patient who has phenochromocystoma complains of symptoms exactly as if he were receiving external adrenaline. He has a vasoconstriction due to the alpha, his pressure is always elevated, he always has palpitations. Palpitations means the sensation of your heart pounding or racing. As if the heart was shaken, palpitations, tachycardia, arrhythmia, and tremors. Okay? In this condition, you have many treatment options. There is a surgical option. If you have the ability to surgically remove it, that's great. But if you can't interfere surgically, then what's the next step? In this situation, I have to block both alpha and beta together. Why? Because the patient has too much adrenaline in his blood and alpha and beta are on the loose. So you can't block only one of them, okay? If I ask you which one would you prefer to block, alpha 1 or 2, you would say I want to block both alpha 1 and 2 together, and also block beta 1 and 2 together, because there's too much adrenaline is making chaos. That's great, here it is. Here we have a drug called phenoxybenzamine, my friend. It even starts with pH, and phenochromocytoma also starts with pH, so they both make a tune. This drug blocks alpha 1 and alpha 2 and it has long duration, as I mentioned, as one tablet lasts for 4 days in your body. So here is the solution to the problem, because this drug helps us with the problem of both alpha 1 and 2. Now this too much adrenaline won't be able to harm you like before, yet something is still missing. Don't you ever give this alpha blocker alone, you must add another drug. I write it in red. It's called propranolol. This propranolol is a beta blocker. It blocks both beta 1 and 2. And I told you, you can't use a single drug, you must use two blockers, the alpha and the beta, at the same time, simultaneously. If someone asks you in the exam, in the oral exam for instance, asks you, what would happen if we used alpha blocker alone? If a patient had a phenochromocytoma and you give it alpha blocker only, tell him okay, if I use alpha blocker alone, then it means it blocks the alpha while the other one is still active, the beta. And when the beta remains active, then all of the adrenaline in the patient's body shifts to it, and all of the symptoms that are attributed to the beta are going to increase, such as tachycardia, arrhythmia, tremors. That's why I can't use alpha blocker alone, he may reply. Then, can you use beta blocker alone? Tell him it would be a catastrophe if I give him beta blocker alone. He may then ask for an explanation. Tell him, it means that we block the beta alone and leave the alpha active? Then all adrenaline would go to the alpha causing severe vasoconstriction and the pressure would change from 170 or 180 and exceed 200 or 300 causing cerebral hemorrhage. So it's prohibited in the treatment of phenochromocystoma that you use a single drug, you must use the two together. An examiner may try to catch you out by making mistakes and tell you that he agrees to using both drugs, alpha and beta blockers together, but which one should be used first? If, for any reason, you have to begin with one drug at first, should you start with the alpha blocker or the beta blocker? Tell him I'd start the treatment plan with the alpha blocker. But why? Because the main concern in this patient is the hypertension. So you are afraid of the hypertension. It's the major problem. First of all, correct the hypertension by an alpha blocker, then when the situation is under control, add the beta blocker to it. If you open the book, you can see there is a dark square on the right in which there is a brief explanation of the phenochromocystoma and this treatment. It says we use phenoxybenzamine in a daily dose of 100 milligrams plus 50 milligrams of propranolol daily. No one will ask you in these doses. Don't bother with numbers, all what you need to know is the name of the drug, why do we use it, and can we use it alone or not. This is all about phenoxybenzamine, and I told you remember only this one use, and don't concern yourself with any other uses. This was in the past and we removed them. Let's move to its adverse effects. What are its problems? Now I hope that you can enumerate them before me while you are watching me try to open your book and tell them to me. Number 1. This drug lowers the pressure, naturally, being an alpha blocker. However, there is a reflex, don't forget about it. Reflex tachycardia, we discussed it. 2. In men, it can cause failure of ejaculation. Ejaculation in men is mediated through alpha 1. When you block the alpha receptor for 3 or 4 days, some men may complain of this side effect. 3. Do you remember when I told you about the eye? And here around the iris is something called radial muscle. And radial muscle contains alpha, which is responsible for mydriasis. Do you remember this? During the physiology introduction. Okay. Now you're blocking this alpha for a prolonged time, for 3 or 4 days. What is the result? Absence of this mydriasis. So what happens? The other muscle, called constrictor pupillae, dominates the area, causing meiosis. As you are stopping the muscle responsible for mydriasis, now we have 3 adverse effects. Of course, there are more, however, these 3 are what we care about. Okay, that's the phenoxybenzamine, we won't give it more time as there is nothing more that you need to know. Let's now move to the next family. Do you remember them? They were just on the board. The second family is called selective. Needless to say, the term selective is music to our ears. Selective alpha 1 blockers. Selective alpha-1 blockers, the head of this family, the boss, the prototype, is called Prazosin. Prazosin. However, we derived from the Prazosin other newer drugs like doxazosin, we made tamsulosin, we made endoramine, and we made many others that end with sin. You can find them in your book. However, I want to draw your attention to something. If you want to forget, forget. But don't you ever forget the prototype. The prototype is extremely important to us. That's why when questions are asked, they either ask about selective alpha-1 blockers or about Prazosin, as it's the head of this family. The others are up to you. Okay, what is the story of this family? Let's discuss their characters and illustrate which uses can they fit. First of all, this family blocks alpha-1 only, not alpha-2. So it's selective, and this means it would prevent the vasoconstriction in your body. It stops the vasoconstriction. Thus, your blood pressure is lowered. Okay? Great. Here is an artery. This is a cross-section of the artery. Now we block the alpha-1 receptor. So the artery is now incapable of vasoconstriction. Not only this, but the drug also reaches the smooth muscles. Let's concentrate on this now. The drug reaches the smooth muscles of the artery, inducing direct relaxation. And direct means an effect that's independent of the receptor, as if the drug induces vasodilation through two methods, like a double kill in a game. It blocks the alpha receptor, preventing the vasoconstriction, and also affects the smooth muscles, inducing direct relaxation through a mechanism that's independent of the alpha receptors. Okay? The result? All of the arteries in your body get dilated, your pressure begins to be lowered. If you are a hypertensive patient, you will improve on this drug. Okay? My next question. The pressure is lowered. Is it for free or you must pay something in return? Of course, there must be a reflex tachycardia, that we mentioned before. Why is the reason for this reflex tachycardia in our bodies? It's some sort of compensation. When the pressure is lowered, your body says, I won't stay still and helpless. I'll induce a reflex tachycardia, hoping for some sort of compensation by the speed and heart. Therefore, these drugs cause a reflex tachycardia, but not to the same extent that is caused by a non-selective blocker. It's written like this in the book. It is a line in the book and I intend to explain it to you so you wouldn't get confused, as it may be a little difficult to understand. Any alpha blocker whatsoever, when administered, lowers the pressure and triggers a reflex tachycardia. However, the book says that the reflex tachycardia that occurs with a selective alpha blocker is not as prominent as the reflex that occurs with a non-selective alpha blocker. To clarify, non-selective alpha blockers lower blood pressure and trigger reflex tachycardia more prominently, while selective alpha-1 blockers lower blood pressure and trigger reflex tachycardia, but not as prominently. It's not as noticeable nor as annoying. What is the reason of this? Let's be fully present and focus on this now. You can repeat this part more than once until you understand it. Even if you don't, no problem. After all, it's not written in the book and rarely required of you. I'll explain it for you just to ease your mind. Let's assume that this is an artery or a blood vessel, and this is a nerve ending, okay? And it releases noradrenaline. The artery contains alpha-1, which causes vasoconstriction. The nerve ending contains alpha-2, which decreases the norepinephrine release. Correct? This is physiology. Now, when you administer a drug that blocks both alpha-1 and 2 together, a non-selective alpha blocker, what is the result? We block this, thus the pressure is lowered. Good. And when the pressure is lowered, it triggers which reflex? A reflex tachy. Not only this, my friend, you have also blocked alpha-2. And when alpha-2 is blocked, this one decreases the norepinephrine. Therefore, by blocking it, norepinephrine starts to build up. And when norepinephrine is increased, don't you ever forget that when norepinephrine is increased, it has a beta-1 effect about 10%. So it goes to the heart, stimulating it. This beta-1 effect of the norepinephrine, it stimulates the heart. Now, tachycardia is triggered through two ways, two mechanisms. Once, when the drug lowers the pressure, triggering a reflex tachycardia, exactly like any other pressure-lowering drug. And once when it blocks the alpha-2, and when alpha-2 is blocked, norepinephrine starts to build up and goes to the heart, stimulating beta-1 in the heart, causing an additional tachycardia to the one that's triggered by the reflex. As if you were trying to say that when we administer a non-selective alpha blocker, the tachycardia occurring in the patient is due to both a reflex and a direct effect as well. One time through the reflex, one time by the direct effect of increasing norepinephrine. However, when you use a selective alpha blocker, it lowers the pressure and causes a reflex tachycardia only. It doesn't increase the norepinephrine that stimulates the heart. Therefore, it triggers a reflex tachycardia through a single component only. So this tachycardia becomes lower than using a non-selective alpha blocker. Please be careful, take time to understand this point, repeat this video once or twice, and write it on the footnote to remember it. Okay, we are still discussing the selective alpha-1 blockers, illustrating their character. I told you that they lower the pressure and trigger a reflex tachycardia, but not that prominent as the non-selective. What else? They said they also don't change the renal blood flow. They don't affect the renal blood flow nor the GFR, which is the glomerular filtration rate. What? You've just remembered the drug, right? You remember the drug from the past video with the name of clonidine. We then mentioned that it lowers the pressure without affecting the renal blood flow, and I told you that this drug is such a fantastic one to control the pressure in the renal patients. Today I'm discussing the selective alpha blockers, which lower the pressure also without affecting the renal blood flow. No harm done. Therefore, renal patients need not worry about these drugs. What's next? Number 3. They said these drugs lower the pressure and improve something called the lipid profile. What does lipid profile mean? It means blood fat analysis. When a doctor asks you to perform a test for cholesterol and also for triglycerides, let's check on them. This is called a lipid profile, okay? These drugs lower the cholesterol and the triglycerides, they both get lowered. So, not only the pressure is lowered, but also blood fats are lowered. No way! All of these benefits? They lower the pressure nearly without triggering reflex tachycardia, don't affect the kidneys, don't harm them, and they decrease blood fats? Such a marvelous family of drugs. Now, the doxazosin that I mentioned earlier, it's called doxazosin. It is considered the longest one of them regarding the duration, regarding the half-life. It stays in your system for about 22 hours. If you encounter an MCQ in which there is a 5 alpha blockers selective that ends with sin, and asks you which one of these has the longest duration of action, pick this one, doxazosin, that starts with D, like duration. So doxazosin is similar to duration. D for D, so it has the longest duration. Now, what are the applications of these drugs, my friend? The first use, you tell me for the hypertensive patients, especially renal patients. And you already know why, because they don't change renal blood flow nor glomerular filtration rate. The second group of patients are those who suffer from a condition called acute heart failure. Acute heart failure means sudden severe heart pump failure because there is a chronic heart failure. Now we are talking about the acute heart failure, okay? This topic in the cardio chapter we will discuss the heart failure. Naturally, we won't discuss the whole topic of heart failure just to understand this use. However, I'll give you an introduction, 2 lines to help you until we reach the cardio. So, when you study there is nothing left for later or left unclear that could annoy you, I'll give you only 2 lines about why we use these drugs in cases of acute heart failure. Look, here is the heart. The heart is supposed to be working with a certain rate and efficiency in all people. For some reason, for example, if this is aorta and here are the superior and inferior vena cava, both are opening in the right atrium, if for any reason the venous return markedly increases, or if the systemic circulation or the systemic resistance markedly increases, if one of these two occurs, either a sudden vasoconstriction and the systemic resistance is markedly increased, resulting in obstructions, or the blood is returning excessively in a manner that exceeds the ability of the heart to pump it. In this case, the heart collapses. It says goodbye. I'm incapable. You're giving me too much work. The venous return is too much, and I can't push all of this amount. Here, the venous return is called preload. Pre-load. Pre-install. And also the other way around. If the preload is excess, the heart tells you, no, I simply can't push all of this. Or if the systemic resistance is suddenly increased, the left ventricle tries to push the blood, but the roots are obstructed and the resistance is increased. It tells you the same thing, I can't. Now should this resistance called pre or after? It's called afterload. Therefore you have two types of loads, preload and afterload. What is the preload? Preload is figuratively called the venous return. The volume of blood that's arriving to the heart in order to be pumped by it. And the afterload, it's the resistance that the left ventricle faces during the stool. Okay, now if there is a sudden increase in the preload or in the afterload, the heart tells you it can't, which is called acute heart failure. The patients become drowsy all of a sudden, can't breathe normally, and 4 people are about to carry him to the hospital now. Such a case is called acute heart failure. In this situation, my friend, what's the immediate response? Of course we are going to treat it, but before we treat it, this is some sort of emergency. You must quickly induce vasodilation to the systemic side to decrease the afterload, so the pathways in front of the left ventricles return patent and the heart can dispose of the blood. And we want this venous return to be decreased, okay? This family, or these alpha-1 blockers, in addition to causing arteriolar dilation, they dilate the arterial side. They also cause dilation of the venous side. Please, focus on this. When you induce a dilation of the venous side, don't you ever think that when you induce a dilation of the venous side, the blood increases? No. When you dilate the veins, these veins were called in physiology capacitance vessels. They swallow the whole volume of blood, and the venous return decreases. When you induce a venodilation, blood becomes swallowed within the peripheral veins. Your 5 or 6 liters get swallowed in the venous side, and the venous return decreases. Because in this condition, when the patient has an acute heart failure and you're giving him a Prazosin or this family, you are in fact decreasing both the preload and the afterload. These are the 2 lines written in the book, but the explanation is not there. When we reach the cardio, you will find all of this detailed information discussed in depth. The third application of the family of selective alpha blockers, I hope you still remember it. Do you remember when I told you that people with enlarged prostate, elder people, elder males, sometimes have enlarged prostates? And it's called benign prostatic hyperplasia or hypertrophy. Prostate when enlarged, this alpha receptor suffocates the urine flow, thus these people always tend to complain of urine retention. They suffer from urine retention due to this alpha. This foolish alpha is a lock. So let's unlock this situation using an alpha blocker. When we use alpha-1 blocker, this alpha receptor becomes blocked, decreasing the resistance to urine outflow. Urine flows downward, thus the condition improves. But there, my friend, the patient may complain of some sort of dizziness. I explained this once during the introduction videos of physiology. Why is he dizzy? Because the drug which blocked alpha-1 here also blocked it in the blood vessels, thus the pressure is lowered and the patient becomes dizzy. That's why, for this purpose, we used to use Prazosin, which is the godfather of this family, the prototype. Prazosin had this bad quality of lowering the blood pressure and making patients dizzy, so we no longer use Prazosin for this purpose. Scientists then decided to pray for God that they might invent a drug that can block the alpha receptor in the prostate only, without affecting the blood vessels, without making patients dizzy. They conducted researches for so long till they discovered that the alpha-1 in the prostate is mainly alpha-1A and alpha-1D. A and D. So they said, bingo, that's it. By the way, most of the blood vessels are the type of alpha-1A and alpha-1B. A and B. However, in the prostate, it is A and D. So they decided to design an alpha blocker that blocks these two with main effect on the D, as it is the one present in the prostate. So they designed a drug within the family of the alpha blockers called tamsulosin. Thus, tamsulosin has become the official sponsor for treating the enlarged prostate worldwide. And if someone asks why only tamsulosin, we have many other alpha blockers. Tell him, because tamsulosin is the only one that selectively acts on the prostate. Why? How is that? It's because it blocks alpha 1A and D, A and D, and this D is not commonly present in the blood vessels. Hence, it improves the urinary flow with minimal change on the standing blood pressure. It doesn't change the standing blood pressure. Okay? We have mentioned the 3 uses of the alpha blockers with all the related details. Now is the time for the downsides, the drawbacks. There is nothing without drawbacks. Here, the drawbacks are called adverse effects. Adverse effects of this family, when you reach their adverse effects, my friend, you can note that they all start with the letter F, as follows. Okay, now the first F stands for first dose syncope. Syncope means sudden drop in the pressure, the patient loses consciousness. First dose means with the first tablet, with the first dose. For instance, the first time for a patient in his whole life to use an alpha-1 blocker, the first time his body deals with it, so with the first tablet the pressure suddenly drops, and when it suddenly drops, he goes through a syncope, he faints. This effect commonly occurs in the people who suffers from salt water depletion. Depletion means the ratio of water in their body is low, or thin people. When someone is very thin and his body water content is low, this effect becomes more prominent on him. And this effect appears within 60 minutes. 60 minutes is the average. It ranges from 30 to 90 minutes after swallowing the tablet. That's why the clever doctor, when he prescribes an alpha blocker for the patient, he asks him if it's the first time to use this drug, and if he confirms, the doctor tells him to avoid using a whole tablet at the first time. Instead, let's divide it to 4 quarters and only take 1 quarter, which means a small dose at bedtime when you're going to sleep. Avoid using it in the early morning. Why? As we are worried that it may be the first time for the patient to use this alpha blocker when going to work, so he may fall on the stairs or fall in the street and people send him to a hospital. So we advise him that until your body gets used to it, take a quarter tablet at first when you're going to sleep, okay, and tomorrow we can use a half tablet, and the day after, 3 quarters of the tablet. We are gradually increasing the dose daily, hoping for the body to go through an adaptation, and starts to recognize this new guest, which is a drug, thus the syncope becomes less likely to occur. This is the first side effect. The first F is first dose syncope. The second F here is something called fluid retention. Fluid retention was mentioned before. We explained it during the discussion of a drug called clonidine, which was an alpha stimulant. And do you remember when I said that we have a rule? I'll remind you of it because I know you are forgetful. Do you remember when I said that we have a rule stating that any drug that lowers the pressure for long periods is confronted by a reaction from the body, but for long periods, not a day or two, say for a month or a month and a half, and the pressure remains low, the body says it won't stand still. This is too much. The pressure is low for too long, so the body starts to trigger a reflex sympathetic stimulation that go to the kidney asking Her Majesty to activate something called renin-angiotensin-aldosterone system. This aldosterone holds your body water, an effect called fluid retention or salt and water retention, hoping that this salt and water retention may balance the drop that occurred in the pressure. This is a rule. Any drug that lowers the pressure leads to fluid retention. And it's better to prescribe an adjuvant diuretic, a drug that induces diuresis or urine flow so the water won't be trapped in the body. Okay? This third F is false positive test for anti-nuclear factor. Hello there. Hello there, new terms. False positive test for anti-nuclear factor? So it may be thought that the patient has rheumatoid arthritis. Easy there, my friend. Everything's so simple. I promise you that there is nothing simpler than pharmacology, nor more beautiful. Easy now, my friend. We have a disease that will be explained thoroughly and to the last detail, called rheumatoid arthritis. A disease that occurs in the joints. It has a long story, being an autoimmune disease. It will be explained in depth in the following chapter. I won't discuss it now, however, I can tell you that this disease called rheumatoid arthritis is diagnosed through some lab tests. Some maneuvers performed in the labs. Among these maneuvers diagnosing it is that we search in the patient's blood for something called anti-nuclear antibodies. Anti-nuclear antibodies. If we see them, the patient is thought to have rheumatoid. Then we look for other signs to confirm it. Now imagine that people on Prazosin specifically, this one, the selective alpha-1 blocker, their bodies form these antibodies that are called anti-nuclear antibodies. But they don't have rheumatoid. These people aren't patients with rheumatoid. But when you take a sample of their blood, you see these antibodies elevated. Thus you think that they have rheumatoid. So it's called false positive. It's not positive. This man doesn't have rheumatoid. No, the test results false positive. Therefore, this drug causes false positive test for anti-nuclear factor for rheumatoid arthritis. I hope it's clear now. The fourth side effect that you may predict to occur with these, we say that opposites attract each other. This drug improves the urine retention. These drugs treat urine retention, as they block the alpha. So it's very reasonable to assume that it worsens the cases of urine incontinence. Please discriminate between the term retention and incontinence. Retention means keeping the urine back. Use an alpha blocker, it will improve. However, incontinence means dribbling of urine without any control. The patient complains that while he is standing still, the urine passed down and I can't preserve my ablution for 1 hour. I can pray 2 prayers with the same ablution. Because whenever I cover something, urine flows out. This condition is called this time urine. Urine incontinence. Incontinence, okay? Good. Here in this incontinence, we want to activate the alpha. This condition of incontinence means the alpha isn't working properly. So you want to activate it. Thus, it's reasonable to say when you use an alpha blocker, this incontinence worsens. And who are the most people suffering from incontinence? Minutes ago, I told you that most people who complain of retention are men, and most people who suffer from incontinence, for no one's better than the other, are females, the woman. Why? Due to pregnancies. With repeated pregnancies, the pelvic floor muscles are weakened, making it harder to control the urine. So the woman with repeated 3 or 4 times vaginal deliveries sometimes complains to her gynecologists from incontinence. As a result of this pelvic floor pathology, pelvic floor muscle damage. Therefore, if this woman receives Prazosin or an alpha blocker, her incontinence increases or gets worse. These are the 4 adverse effects. Now this family has come to an end. Let's move to the next family. The orphan drug, this poor, lonely drug without any siblings, which is the selective alpha-2 blocker. The selective alpha-2 blocker is an impoverished and an orphan drug called Yohimbine. Yohimbine. By the way, when there is a single lonely drug with no siblings, it's called an orphan drug. Don't cry, please. So this Yohimbine is an orphan drug. Why is it orphan? Let's look at how it was discovered at first. It is an alkaloid, a natural substance extracted from a tree grows in the middle of Africa. Countries in Middle Africa has a tree there called Yohimbine. It has this alkaloid called Yohimbine. When they studied it, they found that this drug blocks alpha-2. Do you remember where was this alpha-2? Remind me as I'm forgetful. Alpha-2 was presynaptic. Its function was to decrease the noradrenaline. So when you block the alpha-2, supposedly, when you block alpha-2, norepinephrine increases. Yet, truth to be told, it didn't happen. Why? Because there is a difference between the theoretical ideas on paper and when they are carried out on people. There is always something unexpected. This drug on papers is alpha-2 blocker on papers, and theoretically, it's supposed to increase the norepinephrine release. And it's supposed to be applicable in many diseases. However, on trial, it didn't increase norepinephrine nor it was used in any disease or anything else. They say the unfortunate always draw the short straw. Look where it's found. It originates from the countries in Middle Africa. So when Africa finally gives us a drug which is globally known to be the only alpha-2 blocker, it turns to be useless. We don't know how to use it. So we started to spread some rumors. When a drug turns to be like this, we use rumors. The rumor was spread to make this drug appear desirable and generate profits from this drug despite the fact that it had no practical benefit, nor any clinical use. So drug companies decided to spread a rumor that this drug is an aphrodisiac. Aphrodisiac. Aphro is derived from the word Aphrodite. Aphrodite is the goddess of fertility and love in the Greek mythology. Dasiac from desire. Aphrodisiac, this term means it enhances the sexual desire. So they decided to spread a rumor that it enhances the sexual desire, and once people from everywhere hear about this rumor, they will start to buy this drug. However, it's a rumor. A rumor in our terms means without clinical evidence. So there is no evidence that supports this rumor. So when someone tells you that Yohimbine enhances the sexual desire, being an aphrodisiac, tell him, do you have any medical evidence? Any scientific basis? He would say, no, I don't. Tell him, then it's just a rumor. These are the works of rumors and gossip. To sum up, Yohimbine is an alpha blocker. We didn't make any similar drugs, as it turned to be extremely worthless. It didn't have any use, it didn't increase the norepinephrine, nor it had any clinical use. And if someone tells you that it's an aphrodisiac, tell him, no problem, let's go along with these rumors, without clinical evidence.